Greetings from IJA. I, Dr. Kiran Mahendru, will present an original article published in the November issue of IJA. It is on the adductor canal block plus infiltration of the posterior capsule of knee block versus the 4-in-1 block in arthroscopic ACL repair, a randomized study. ACL injury is the most common sports related injury of the knee, which has significant potential for postoperative pain. It requires a combination of balanced analgesia, patient satisfaction, and early ambulation for full functional recovery and early discharge. Strategies with multimodal analgesia include the femoral nerve block, adductor canal block, ACB combined with injection between popliteal artery and the capsule of the knee, that is IPACK block, or analgesia with local infiltration. Femoral nerve block is known to cause lower limb motor weakness in 49 to 80% of the cases, resulting in risk of falls during rehabilitation. Adductor canal block is a simple, reliably efficacious, and motor preserving block which has shown to produce only 8% motor involvement. The sciatic nerve block, when combined with the femoral nerve block in ACL repair surgery, provides improved analgesia and reduced opioid requirements, but the sciatic nerve block can cause sensory motor deficits, increasing the risk of fall. Optimal regional anesthetic techniques should provide analgesia to the anterior and posterior knee nociceptors with no motor weakness. The IPEC, that is infiltration of the posterior capsule of the knee, provides adequate analgesia for posterior knee pain while preserving the motor function. The 4-in-1 block is a single injection technique which has been compared in TKR with successful outcomes but has not been studied for ACL reconstruction. The primary objective of this study was to compare the analgesia provided with regional analgesia technique of IPEC plus ACB versus 4-in-1 block on postoperative pain scores in patient undergoing arthroscopic ACL repair under subarachnoid block. The secondary outcomes were to observe the rescue analgesic consumption and the hospital length of stay duration in these patients. The hypothesis was that post-op analgesia provided by the single injection technique 4-in-1 block is comparable to already established combination of IPAC with ACB for ACL repair. It is a double-blinded randomized control study conducted between June 2023 to November 2023, registered with the CTRI, and included patients undergoing unilateral arthroscopic ACL repair between the age group of 18 to 70 years of either gender, with complete preoperative checkups and optimization falling in the ASA class 1 to 3. The patients excluded were with cardiopulmonary dysfunction or poor cardiac reserve with the LVEF of less than 35%, with bleeding diastasis or coagulopathies, on anticoagulants like aspirin or clopidogrel, infection at the site for block, contraindication for regional anesthesia, allergy to local anesthetics, previous neuropathy on the operative limb, or denial to consent for participation. The computer-generated random table was used for the randomization process where Group A patients received ACB with IPEC and Group B received the 4-in-1 block. Random group allocation was sealed in opaque envelopes by the OR manager, which was handed over to the senior anesthesiologist who conducted the anesthesia, performed the allocated intervention, and did the intraoperative monitoring. The regional analgesia technique was performed using portable ultrasound, a 10 centimeter 22 gauge echogenic nerve block needle with 0.2% ropivacaine and dexmed in the concentration of 50 microgram per ml in a 20 ml syringe. Surgical skin preparation was done with antiseptic solutions, sterile gauze, sterile drapes, and sterilized camera covers were used for the sterility. The observer recording the parameters and the VAS scores was blinded to the allocation and the intervention performed, and the patients were also blinded to the allocation and intervention. Complete PAC and optimization were done. Pre-medication was done using oral Alprex 0.25 mg administered the previous night of surgery, oral paracetamol 650 mg, and oral S-omeprazole 40 mg with domperidone 10 mg administered in the morning with sips of water. 18-gauge IV cannula was established and balanced salt solutions were started at the rate of 2 ml per kg per hour. After attachment of the standard monitors, spinal anesthesia was given using 25-gauge Quincke Babcock spinal needle with 3.4 cc of 0.5% levobupivacaine in sitting position. After the desired effect was checked in supine position, IV dexamethasone 8 mg was given for prophylactically for PONV and IV midazolam 1.5 mg was given for sedation. Then a guided nerve block was performed as per the protocol. A standard mixture of 25 ml of 0.2% ropivacaine and 50 microgram of dexmed was used for the intervention. Time to performance of block for needle insertion to removal after successful completion of block was noted by an observing OR technician using a mobile phone stopwatch. The group A received the IPACK block in the supine position with knee flex and limb externally rotated. The popliteal artery was identified over the femoral shaft and needle was used in plane from medially to laterally till the tip was seen between the bone and the artery, and 10 ml of the drug was given and 5 ml infiltrated while removing the needle flush. The adductor canal block was given using a linear probe in the mid thigh. Sartorius and superficial femoral artery were identified, followed by lateral to medial in plane needle insertion towards the superficial femoral artery, and 10 ml of drug was injected. In group B, in the supine frog leg position, that is, knee slightly flexed, slight abduction and external rotation, a high frequency probe identified the medial femoral condyle. And then the intersection of vastus medialis and sartorius and superficial femoral artery were identified. The probe was moved proximally to identify the descending genicular artery just 1 centimeter proximal to this branching. The needle was inserted in plane from lateral to the medial side, and 25 ml of drug was injected in a single injection to push the femoral artery posteriorly with every 2 ml of aliquot of injection. The intraoperative data recorded were the hemodynamic parameters, the block performance time, starting from the needle insertion to the removal, and the duration of surgery. Multimodal analgesia was provided using IV paracetamol 1000 mg every 8 hours, IV tramadol 25 mg every 8 hours, and IV diclofenac 75 mg diluted in 100 ml normal saline every 12 hours. IV tramadol 50 mg diluted in 100 ml normal saline was given when the VAS score was more than equal to 4. It was advised as the rescue analgesic. The protocol for complications, if any, was defined. For example, in case of any inadvertent vascular puncture, the block was abandoned and immediate compression was done of the injection site for 10 minutes. The study participants were observed closely for next 24 to 48 hours for any other vascular complications and were dropped out of the study. The primary outcome was post-operative analgesia using the VAS scores noted at 3, 6, 12, 24, and 36 hours. The secondary outcomes were rescue analgesic requirement noted at the same intervals based on a VAS score of 4. The duration of spinal anesthesia motor blockade assessed using the Bromad score. Lower limb motor weakness due to nerve block was examined using the 4P acronym method assessing the push, pull, and punt for the sciatic nerve. Femoral nerve assessment was done at the same intervals to determine the impact of interventions on the length of stay. The sample size was calculated using mean VAS scores at 24 hours from a study done by Roy et al. And total of 184 patients, 92 in each group, were considered using a 5% inadvertent dropout rate. SPSS 25 was used for the statistical analysis. Now, this is the consort diagram showing that total of 184 patients were randomized with 92 included in both the groups. The demographic data was comparable between the two groups, and as you can see from the results of the study, the VAS scores were seen at 3, 6, 12, 24, and 36 hours. The score was statistically significantly lower in group B at 36 hours. Also, the time to perform the block was less in group B because of the single injection technique used. Also, you can see that the time to rescue analgesia was also significantly later in group B, that is 4-in-1 block, as compared to group A, in which ACB and IPACK block were given. Rest of the parameters were comparable between both the groups. This study found comparable VAS scores in the 4-in-1 block and the IPACK plus ACB groups, confirming the hypothesis. The findings were similar to those of Roy et al., who compared the interventions for analgesia for post-knee arthroplasty. The time to perform the 4-in-1 block was significantly lower than the combination block, while the interventions did not interfere with or delay the post-op physiotherapy and the discharge. Therefore, 4-in-1 block is logistically easier to perform with least side effects. 9.34% of study participants required rescue analgesia, of whom the requirement was significantly earlier in the IPACK plus ACB group. Along with typical findings of VAS lower in 4-in-1 group at 36 hours, which could be due to the higher volume of a single injection point. IPACK block provides posterior knee analgesia, and combining it with the adductor canal block provides adequate analgesia for arthroscopic ACL surgery. The basis of drug spread in 4-in-1 block is supported by a cadaveric study where 10 ml of dye in the distal adductor canal spreads to the nerves such as saphenous, medialis vastus, popliteal plexus, and posterior division of the obturator. The limitations of the study are the lack of motor block assessment, which requires multiple tools for complete objective assessment, and detailed VAS assessment at rest and on movement, which could have validated the effects of the intervention studied. Interventions such as 4-in-1 block also need minimum effective volume determination for comparable effectiveness. Extensive studies are required to validate the findings regarding early rehabilitation, and the safety of the technique also needs to be assessed and validated. Therefore, the authors concluded that the 4-in-1 block provides non-inferior analgesia compared to the established infiltration of the posterior capsule of the knee plus adductor canal block for arthroscopic knee surgery. Thank you.